Thanks, Dr. Kulkarni, for joining me in this conversation today. Women's health, as you know, is not really talked about. You know, what we know, what information is there, is all in fragments, you know. Here and there you get tidbits of information, and it's never the real information. So your expertise is really going to help our viewers, you know, understand, you know, women's cancers the way they are today, right? So many thanks, and probably we'll dive in with just a little bit of the basics.
I think it's great to be part of this program, Sanjukta. I'd be more than happy, to contribute the information that I have. If it percolates down and if it helps women, I would be really satisfied with it.
That is the basic idea. Thank you so much, doctor. So let's dive in. I want to start with something very basic. Can you take us through the different kinds of women's cancers there are? You know, sometimes I've come across in my research in the last 7 years of my reporting, I've come across things like basics people are not aware of. Like what is an ovary? Many people don't know. So to start with, what are the women's cancers? What are the gynecological cancers that happen to women? And just explain it to us in very simple way to understand.
So I think when we talk about women's cancer, you know, what we are talking about, there are certain cancers which are specific to women, okay, which are not seen or rarely seen in men.
Right.
So, you know, if you talk about gynecological cancers, it's basically cancers that deals with gynecological organs or feminine organs. So you take uterus, fallopian tubes, ovaries and cervix, which is basically part of the uterus. Now, most of the cancers in women are basically ovarian, cervical and uterine as far as gynecological cancers. And when you add breast cancer, that essentially completes almost 80 to 90% of the cancers that are seen in women. Okay,
right.
So when we talk about ovary is basically an organ which is meant to do two functions. Okay, the important part is obviously to produce a female oocyte or a oocyte that is required for fertilization, and it also provides hormonal sort of balance in a woman. So the feminine characteristics, the estrogens, are basically provided by the ovaries. So we should not look at ovaries as only an organ which is required for pregnancy. It plays a far more important role in a woman's life apart from, you know, allowing them to be pregnant. Say uterus, we all know the basic function of uterus is basically to hold the baby for you. And the lower part of the uterus is the cervix. So if you complete cervix, uterus and ovaries, that essentially, you know, are majority of the gynecological cancers that we see in our practice. There are other cancers like vaginal cancers or vulval cancers, but they are much rarer as compared to these three cancers.
And Dr. Kulkarni, you're essentially a surgeon, so your expertise is of course beyond consultation. You do the surgeries, right? So for example, ovarian cancer, there's the debulking surgery, right? It's a very major surgery. It often changes a woman's body. It can be very debilitating. It takes a long time to heal. What are the advances, would you say, in surgical interventions in women's gynecological cancers specifically that have come up which makes things better, maybe?
Yeah, so I think one of the biggest, evolutions, as I say, in surgery would be the role of minimal access surgery. So you can talk about laparoscopic surgeries or robotic surgeries. Now, the biggest advantage of minimal access surgeries is that the scars are less, the pain is less, the recovery is faster, and the hospitalization is lesser. So you get back to your normal life much quicker as compared to a conventional surgery. Now, can we do minimal access surgery in all cancers or all gynecological cancers? The answer is no. It's a technology which has its limitations. So I think you have to be very careful in selecting which are the patients you are subjecting for minimal access surgery. But in terms of improvement in quality of life and recovery, minimal access surgery plays a very important role. Can I use minimal access surgery in ovarian cancers? Barring very few exceptions, majority of the times the surgery for ovarian cancer is a conventional one. Are there any advancement? Yes, there are advancement in terms of better antibiotics, better anesthesia facilities, better post-operative care facilities, better rehabilitation facilities that makes life and the recovery much smoother and better for patients. There are certain newer techniques like HIPEC, I don't know, which is basically a hyperthermic intraperitoneal chemotherapy, which is given at the time of surgery. Apart from giving conventional chemotherapy, it has been proven to improve survival in women with ovarian cancers. Okay, so there are certain advances which have been made. I won't say there are big changes in terms of the way we do the surgery, but yes, minimal access surgery and HIPEC are probably the two things that I can suggest where we have moved on from the conventional lines.
And generally in gynecological cancers, doctor, how crucial is the surgery in the outcome, in prognosis?
No, we can't call it as every cancer will have different aspects of treatment. Say, let us say the most common gynecological cancer in women is cervix, right?
Okay.
Now, in cervical cancer, majority of the patients that come to us are basically stage 2, 3 and 4, where there is absolutely no role for surgery. Okay. So surgery plays a very crucial role in probably early cervical cancers. Come to endometrial cancers, where surgery is mainly the part of treatment. The same applies to ovarian cancers, where surgery and chemotherapy play an equally important role in terms of achieving better outcome. So it depends, the role of surgeons it varies depending on cancer to cancer. What we should look at is basically holistic treatment, okay, which includes the surgeon, the medical oncologist, the radiation oncologist, the rehabilitation, the physiotherapy. They all contribute towards improvement of patients' quality of life as well as survival.
Right. So you have been in this field, say now for I guess 25 years. You were at Tata Memorial Hospital and then you came to Kokilaben Hospital. So over these last 25 years, doctor, what are the changes you have seen? Of course, in terms of treatment, of course, new things have come up. But in terms of incidence, in terms of awareness of these cancers, in terms of how people's attitudes to it, people, how they take it, because often these cancers are associated with shame also. There's taboo attached to it, there's shame attached to it. So what are the changes you've seen?
So I think let us start with incidences. Okay, probably when I started my training, cervical cancer was the #1 cancer for women in India. Today it has been overtaken by breast cancer. So breast cancer is the most common cancer, followed by cervical cancer, followed by ovarian cancer. So that is #1. I think, in terms of patient awareness, we have moved forward, but I don't think we are where we should be. Okay, right. I think a lot of people are not aware, are afraid, do not have access to healthcare facilities. So all in all, in combination, if you see the proportion of patients that comes to us or any other medical institution in advanced stage is far more in India as compared to the developed world. So we have a lot of patients who come at a much advanced stage where the cancer could have been diagnosed much earlier and it could have been treated more effectively. So that is one thing that we look at. In terms of shame, I think one thing what I have realized, I am a gynecologist by training and I have been dealing with women, in terms of their medical problem. I think women are far stronger than people give them credit. Okay, and what I realize, majority of the time you have a family who will come in and they would say, no, please don't disclose it to her. We don't want her to know. But I insist that they should be aware of what condition they have. They should be part of the decision making process, and they take it much more strongly and confidently and positively than what their family anticipates. So I think that is something that I have realized. Okay, so shaming, I don't think I think we as a society, at least in urban class, have passed that. I think people do understand that it's just unfortunate that somebody has a cancer, but I don't think there is a lot of social stigma that is attached to it.
Okay. So besides, of course, the right treatment, the right doctor, are there any sort of external factors that can help a woman overcome this easier, better?
I think treatment is just one part of it, and I always say to my patients, or I always think as a doctor, that whenever there is a cancer patient in the family, it affects the entire family.
True,
okay, and
true.
I think this is the time where the whole family has to rally around the person who is suffering, be it male or female, and I think they need the emotional support most at that point of time. And
Right.
as we all would agree, a person is most vulnerable when they are not well, and when you are not well with a disease like cancer, I think you require all kind of support. So they require emotional supports from their family, they may require counseling, to understand and help them go through the process. Obviously there are medical feedbacks which are given by us and the team around us, but at the end of the day, what the person thinks in their mind, and I think where positive thinking really helps them. Okay, because and the most important thing is they have to just cut out the external noise. They should just speak to people who matter to them and who will give them correct advice. Lot of times, somebody says something and it affects them, and I think that is something that they should just stick on to what the information that their medical care professionals have provided them, and just understand that. I think there are a lot of misconceptions and sort of false things that are going around, and once they hear them, that just brings them down. So one day you see a patient who is very happy, evening the neighbor comes to visit them, and next day morning they are depressed.
True.
Okay, I think that's where the family needs to come in and help them.
So careful and cautious about who you are
Who
talking
you are
to,
talking to and
whose
what you are
advice you're
talking to.
taking. Right, right. I want to come back a little bit to the treatments now. Doctor, is the picture of genome testing, say for ovarian cancer, and I'm not aware of the others that much, is that something that has really changed the paradigm for ovarian cancer in terms of the new treatments that have come based on genome testing? And how are we in India sort of equipped to do, go in for such advanced treatment, advanced diagnostics? Can you tell me about?
Yes. So I think, obviously, so just to put things in perspective, okay, say you have 100 ovarian cancer patients, okay,
Right.
you treat all 100 of them in the same way, because there are guidelines how you are going to treat an ovarian cancer patient. Out of them, 30, all of them, say, assume that they are all of the same stage, okay, similar type of, disease. 40 to 45% of them will survive, and 55% of them would not, okay, as per the statistics. And now this testing is about identifying what is different in those 45 who survive than those 55 who do not. Okay, so I think the whole idea of this testing is not only understanding what happens, it is about understanding the basic biology of the disease, okay, and what we think, majority of the time you take decisions based on what you see under the microscope, but the changes are actually happening at the genomic level, and the whole idea of understanding that and then trying to rectify. And the best example of it would be, say, a BRCA1 or BRCA2 positive women and the PARP inhibitors, and the impact that it has on the treatment of ovarian cancer patients as a maintenance treatment, which is much easier for them to take, barring the cost that is involved in it. So this is where it is changing things. We don't even have about 5% of the understanding, but that is, in fact, even that much understanding is making an impact in terms of patient outcomes. That is one. Are we ready for it? Yes. I think, India is there. There are a lot of labs which are providing all these supports. All these tests are done, and they are done at a reasonable cost as compared to, say, when you have to outsource it to Western countries. So we have labs in India which are doing those tests at a reasonable cost. What you require is you have a test, and that says me that okay, certain XYZ gene is abnormal, or XYZ pathway is not working right in a given ovarian cancer patient. What is missing is not all the pathways that you find abnormal, you have solutions. Right now you have solutions for 1 or 2 pathways. Okay, science is working, and eventually you will try to find out solutions to most of these pathways. Currently we have limited role for genome testing and the treatment or targeted treatment based on that. But yes, I think that's probably the most exciting part of cancer treatment, because the only way the cancer treatment can evolve is by understanding the biology of the tumor.
Can you elaborate a little bit on when you say it has to, not just what you're seeing under the microscope, it has to go to the cellular level, which is the genomic level, right? So can you elaborate, can you explain that a little bit?
I can explain you something about very similar to what happened in endometrial cancer or a uterine cancer. For all these years, we were treating uterine cancers based on, what we see under the microscope. Then there come the Cancer Genome Atlas and the Cancer Network, which told us that it's not all endometrial cancers are the same. There are 4 different molecular types of endometrial cancers, and they all behave totally differently. So there is one group, I don't want to sound too technical, but there is one group called as Pol E, okay, and they have 100% survival. Okay, and there is one group which is called as copy number high or P53 abnormal, and they have a very poor survival. And so the idea of it that all 100 patients, which I thought all are same, by molecular typing I have been able to divide them in 4 different groups, and each group has a different set of treatment. So that's the whole idea of this, that you tailor the treatment. So in ovarian cancer, you have BRCA1 and 2, and they have this what we call as homologous recombinant deficiencies, and that pathway, where the PARP inhibitors work. So you have identified the problem, you have identified the solution, and that's why in those subset of patients it works beautifully.
So are enough ovarian cancer patients doing these kind of tests, and is the PARP inhibitor still a very sort of rarefied, sort of expensive drug that's not accessible to everyone, or has it changed a bit?
Yeah.
Because it seems like a drug, I'm on various support groups and all that. It seems like a drug that has made some difference to survival and prognosis of ovarian cancer patients, and because of the cost factor, how can it be accessible to people? Are there any clinical trials? Are there any sort of anything that helps?
Yeah, so I think first part is, are we doing this testing in patients? Yes, because the current guidelines says that all women with high-grade ovarian cancers need to undergo the genomic testing for BRCA1 and 2, and if they are not positive for that, then we do somatic BRCA1 and 2, and we do HRD testing for all those patients.
Right.
Now the BRCA1 and 2 as well as the somatic BRCA1 and 2 are much more affordable. The HRD testing is much more expensive, but there are Indian labs which are doing it at a competitive or a lesser cost.
Okay.
One. Now as far as PARP inhibitor, yes, when PARP inhibitors came to market and the trials and the data that backed the drugs, it was very exciting, and it is exciting. Obviously, the biggest prohibitive factor for its widespread use was its cost.
Yeah.
Okay, and the costs were pretty high, but now there are Indian generic versions which have come, which are offering the same drugs at a much lesser cost.
Okay.
So nowadays, obviously, when the drug comes initially, there are a lot of trials. I don't know, but I'm not aware, but I don't think there are any trials which are recruiting patients for olaparib, because now it's a foregone conclusion that majority of the patients who are BRCA1 and 2 positive or HR deficient are going to benefit from olaparib. But there are Indian versions which are available, which are almost 1/5 or 1/6 of the cost of the original drug, and so it is so. For first 4-5 years, I may have had about 15-20 patients who were taking olaparib. Today, the number is almost 145. So I think obviously it will change, and there will be a lot more women who will be able to take PARP inhibitors in case they do require it.
Okay. I want to come a little bit to cervical cancer. So worldwide, cervical cancer seems to be in very good control, of course, after the HPV vaccine came in. But in India, still, I was looking at the data, the latest data says average of 75,000 Indian women are still dying from cervical cancer. So is it because the vaccination drive is not working, or is it lack of awareness? Why do we still have cervical cancer patients in India?
Yeah, so I think there are 2 aspects of looking at it. When you look at the cervical cancer incidence 20 years back and today, we have come down.
Yeah.
Okay, the number of cases, new cases of cervical cancers have come down. and that is without any active intervention either by on the government side, or there is no major awareness campaign or something, or people are not more aware. It's just the incidence has come down because of people accessing, or what we call as a random screening, or better hygiene, better genital hygiene, understanding the sexual practices much better. That is one. We are losing more lives, women dying of cervical cancer because they are coming at a very advanced stage. Okay. Now, the difference between Western world and us is basically majority of the Western countries had an organized cervical cancer screening program, which we don't have. So most of the times in India, the screening happens what we call as opportunistic screening, okay, where a woman comes to a gynecologist and they just undergo a pap smear as a part of their routine checkup. There is no organized screening program. Now, to be honest, I think there are a lot of Indian groups, especially from Tata Hospital, which have worked on low cost screening in low resource settings, and they have shown to be very effective. So that is going down, that is percolating down, so that will help in terms of reducing the incidence of cervical cancer. The other thing is about vaccine. I think Prime Minister himself has spoken in the Parliament about the need for cervical cancer vaccine, and I think Serum Labs are producing sort of Indian cervical cancer vaccine. So once it becomes a part of the vaccination schedule, it will improve the vaccination percolation across all stratas of society.
Yeah, and I guess this number also will have a lot of rural women, right?
Yes. Yes, cervical cancer essentially is a disease of underprivileged. I think that's how you look at it. So in rural India, where absolutely no facilities, and especially the diagnosis part is very late. They tend to ignore their symptoms for long, and by the time they reach the medical care, they are already at an advanced stage where cure becomes lesser and lesser.
So, Doctor, we are all constantly sort of being reminded in everywhere that cancer cases are rising. It's not like worldwide there are more cases of cancer. There are so many advances, so many therapies. Same with gynecological cancers. So I don't know if it's unique to India, specific to India. Why is it rising? Is there any sort of factor? Because say our moms and our aunts era, I don't know if there were many breast cancers or ovarian cancers or cervical, but now it seems to be much more common. And so is there any kind of factor? Are there environmental factors, lifestyle factors can contribute? What is happening?
Yeah, so I think there are two aspects of looking at it. One, there might be cancer which was happening at that in their era and which was not diagnosed, and that is one part. But to be honest, you look at the lifestyle of the previous generation and the lifestyle of today's generation. Okay, so you had say a lady who would give birth to 2 or 3 kids. Okay, they were breastfed. Everybody of them would be breastfed. Okay, they would work, they would exercise. There was less of all this crap food that we all eat every now and then. So all those things that would protect them from the biggest cancers are already there. Okay, so you have pregnancies and breastfeeding that would prevent not only from breast cancer, will also prevent from ovarian cancers. So there, and lifestyle, basically exercise, good food, good healthy habits is going to reduce, and unfortunately the stress and the push and pull of day-to-day activities is everybody is losing on that. Okay, so when you look at the classic example is breast cancer, which was not even a big factor in India say 25 years back. You see today, and they say there is going to be a tsunami of breast cancer in another 20 years in India, and that can purely be described or purely be blamed on the lifestyle changes. Okay, so majority of the women are career oriented, and which is nothing wrong in it. But you have late marriages, late childbearing, they have to go back to work, the child may not be breastfed, so all those factors are working, in sync in order, so that's the reason why we are getting a lot more cancer cases.
So for gynecological reasons, it's good for a woman to be pregnant at the right time. if they want to be
yes,
pregnant,
yes.
right?
So there is, now you look at the risk factor for cervical cancers. Okay. And now cervical cancer, the risk factors are sexual intercourse at an early age or multiple sexual partners, and for ovarian cancer, multiple pregnancies, or for breast cancer, it is actually protective. So I think what we need is basically balancing out everything. Okay, I think you have to understand which are the risk factors for what, and the only way you can change it is by awareness. I don't think any government program, in terms of therapeutic interventions, will not bring down the cancer incidence. It's basically you have to start at school level and make them understand about the risk factors, and that's where we will see the results in another 20-25 years to come.
Okay. Prevention is of course key. I want to talk a little bit about prevention. What do you want to tell young women today, say women who have just come out of college, just started working, just got married, or what do you want to tell them about staying on top of this? Should they be incorporating certain tests to stay ahead of, if they're sort of inclined to having gynecological cancers? What can women do to of course you talked about the lifestyle, but I'm talking about, say, specific tests.
Yeah.
Like, say, the CA-125 test, which, I do for ovarian cancer. Can that be is that a part of an annual package of tests for women?
So I think, here we have to keep science and emotions away. Okay. I think scientifically there is no data that suggests ovarian cancer screening improves mortality. Okay. So currently, whatever test that they have done is basically that have shown that screening is very useful for women who have high risk for ovarian cancer, who have a strong family history, or who are BRCA1 and 2, positive. Those are the women where screening is going to help. As of now, ovarian cancer screening is not recommended for general population. Now, CA-125, you talked about CA-125, but there are, I'll tell you the flip side of it. So a lot of people go for annual checkups. So CA-125 is included as a part of it. Suddenly the CA-125 comes at, say, 65. Okay, and they are all stressed out, and they come to me or any doctor as to why this is. Do I have a cancer? Because see, unless there is a specific marker, CA-125 is not a specific marker for ovarian cancer.
Oh, it's not?
No.
Okay.
CA-125 can be raised in benign conditions like endometriosis, fibroids, pelvic infections, benign ovarian tumors. So CA-125 does not have a diagnostic value. It has a prognostic value. So what is prognostic value? Say I have a patient of ovarian cancer who has a very high CA-125. I treat her, and then I look at the CA-125 values to see how my treatment is working. Okay. So including CA-125 as an annual package is good, but you have to understand that CA-125 high does not mean that you have an ovarian cancer. So that is one part of it. Now for cervical cancer, definitely yes. Okay. I think the HPV vaccines are available in India. Okay, the best age to vaccinate is before you actually have exposure to HPV. That is, HPV is basically sexually exposed. Okay. So you have the vaccine, say, between 9 to 14 years of age. That's the best time to vaccinate.
After puberty?
Not necessarily, 9 to 14 years.
9 to
That's
14.
best.
Okay.
You can take the recommendation that you can vaccinate up to 45 years. Okay? But the best effect and the response of the vaccine is between, when you give it between 9 to 14 years, you can do a catch-up vaccination between 15 to 26. After 26, whether you do vaccination or not, you still have to go ahead and, with your pap smear or annual cytology, every 3 years cytology. Okay, so HPV vaccination is something that can be incorporated in the vaccination schedule. And lastly, for cervical cancer, there is a very simple test, okay, what we call as pap smear, which need not be done every year. Now the guidelines have changed. You have to do it every 3 years. There is also an advanced test called HPV DNA testing, which has to be done every 5 years. So you can do those tests, and that should be enough. So I think you have a healthy lifestyle, because there are certain cancers which you can't, sort of pick up early. There are some cancers which you can pick up early. So I think doing a pap smear once you are beyond 25, getting an annual ultrasound done is nothing wrong. But as I said, in young women, there are a lot of times there will be ovarian cysts which will have no relevance. They will not be cancerous. And people get very anxious about it. So I think we have to be realistic about what is really going to help you and what is only going to increase your anxiety.
And what about symptoms, doctor? Like in terms of how you're feeling, are there any symptoms you can look out for? Of course, breast cancer, you can do self-examination. If you find lumps, that is pretty easy, right? Like for me, ovarian cancer, it's very vague symptoms. It starts with some, for me at least, it was very vague. I mean, it was like a stomach upset, So can there be any sort of guidance about symptoms to sort of be aware of and go to a doctor if you get those symptoms?
I think for gynecological, and one of the most important symptom is abnormal or irregular bleeding, okay? Because that's the time where you need to go and see your doctor. Ovarian cancer, unfortunately do not have very specific symptoms, okay? You have this bloating and indigestion and constipation, and say a 35-year-old woman has this, nobody is going to think that she has an ovarian cancer.
Right.
But what I feel is, after your regular medication say don't work for a couple of days and it's still persistent, it's better to see your family physician or a gynecologist, okay? And get yourself evaluated. A basic ultrasound at this level can actually help exclude ovarian malignancy, okay? So I think when the symptoms are persistent, any symptom, especially gastrointestinal symptoms are persistent, it's better that you see a doctor at that point of time.
Okay. And after menopause, do chances of women's cancers, gynecological cancers become higher?
The incidence is
higher after menopause?
Yes.
Okay.
Yeah. Majority of the gynec cancers are seen between 5th and 6th decade of life. That is between 50 and 60 years. Okay, that is where the peak age incidence, as we call it, is there. It doesn't mean that it doesn't. People less than 50 also have it. Women more than 60 will also have it. But you will have the peak incidence between this decade of life.
So again, doctor, I want to end with this. For women between 50 and 60 who are also handling menopause and who are sort of probably becoming aware that I have to go for screening, what do you want to tell them? What do you want to say? Tell them to remain healthy, to sort of lessen their chances of getting any of these cancers.
Yeah. So my thing is, don't be afraid, okay? Second thing is, take care of your health, okay? I believe a woman is the center of every family. A woman who is not, if the woman in a family is not well, the entire family goes haywire.
Yes.
I think for them, screening is a very simple thing, okay? And there are not lot many screening tests that are available for lot many cancers. There are a couple of tests that you need to do, and that can prevent devastating, sort of complications that can happen in case if you miss out on something. So I think majority of the times it's not the lack of resources, it's just the inner fear that something may come out wrong, that we have to overcome. I think the resources are available, at least in urban India. Nobody can complain that the resources are not available. And the second thing what I want is here to highlight is about finding the right doctor, in case if you are diagnosed with a cancer. I think across specialties it has been proven that specialist care improves survival, okay, improves outcome, okay? So I think that's where, so it's not for only cancers, it's for any medical condition. I think you should invest certain amount of time, in finding out who are the right doctors to treat this condition for you. I think that makes a difference in patient outcomes.
Yeah, and in terms of lifestyle, you said exercise, good health, eat healthy.
Correct.
And stress.
Yes, less amount of stress, but that is something that nobody can avoid.
And what about environmental factors? Like, what about the air pollution? I mean,
I think that we all can't do anything about it, except and at the end of the day, there are certain things which you can't change. There are certain things which are under your control which you can change, okay? So I think air pollution and all, whatever we said and done, I think if you talk to Delhi, they say Mumbai is heaven, okay? So it's very sort of relative kind of thing, but there are certain things which they need to be aware of, the tests that are available for them. There are certain modifications that they need to make in lifestyle to reduce their risk of cancer. I don't say nobody can bring it down to 0%, but you can definitely reduce the risk of cancers.
Okay. Thank you so much, Dr. Kulkarni.
thank you.
This
It was
was
my
very
pleasure,
useful.
Sanju.
Yeah, this is
Thank
going to help a lot of women, I think. So many thanks for your time. I know your time is precious.
Oh,
so
no,
this
no.
was
It was my pleasure,
amazing.
Sanju.
Thank
I
you,
loved
doctor.
interacting with you.
Thank you.
Thank you.